Myeloproliferative neoplasms are clonal neoplasms with a tendency towards an accelerated phase or blast phase disease. When we talk about acute myeloid leukemia post-MPN, we are referring to that blast phase disease. This tendency is much more so in patients with myelofibrosis as compared to PV or polycythemia vera, which in itself is more so than that from essential thrombocythemia. There are certain genetic alterations or mutations which do correlate with a slightly higher risk for having leukemic transformations. I do want to state that post-MPN AML is one of the toughest acute myeloid leukemias to treat. These patients in general do not have as good outcomes as those who have de novo AML. Traditionally, the treatments have included chemotherapy, intensive chemotherapy, but also less intensive chemotherapies like hypomethylating agents, as well as hypomethylating agents with different additional combination drugs, including venetoclax, for example. The key message, though, however, would be that if we can get these patients to have a reduction of their blast count, ideally in remission state, though, these patients should be taken for allogeneic stem cell transplant in order to have the highest chances of a cure and meaningful remission status that can ongo. That can be hard to achieve given that these patients are frequently on the older end and may not achieve remission. I think also important to note in this space is the use and the excitement around alternative drugs, which may afford more disease-modifying activity and a potential to get into remission, be that on the backbone of intensive chemo or less intensive chemo. And these drugs, for example, and I'll just name two, include BET inhibitors as well as MDM2 inhibitors like navtemadlin. However, these are currently being investigated in ongoing clinical trials, and we look forward to seeing more data down the line.